Welcome to the second video in our series on hypertensive crisis. Today we are going to focus on hypertensive emergency, which is the critical condition where blood pressure exceeds 180 over 120 millimeters of mercury and is accompanied by acute end organ damage such as acute heart failure, aortic dissection, acute myocardial infarction, pulmonary edema, stroke, hypertensive encephalopathy, acute or chronic kidney disease, hypertensive retinopathy, microangiopathic hemolytic anemia, and acute liver failure. This requires immediate ICU admission, continuous monitoring, and careful blood pressure reduction to prevent further harm while also avoiding ischemia from overly rapid lowering. So we are going to cover how to recognize it, initial stabilization of the patient on arrival, evidence-based intravenous therapies, diagnosis-specific management, transiting from the IV medication to the oral agents, stepping down care from the ICU to the general wards, and essential follow-up. Patients present with symptoms that reflect the specific organ systems involved. For the heart, they present with complaints of acute chest pain, easy fatigability on exertion, swollen neck, palpitations, difficulty in breathing, or swollen lower limbs. For the lungs, they present with complaints of severe difficulty in breathing, chest tightness, productive cough, or wheezing. For the brain, they'll be having complaints of severe headache, often described as the worst headache of their lives, nausea, vomiting, confusion, altered mental status, seizures, focal neurological deficits like hemiparesis, facial droop, slurred speech, or vision field defects, or coma. For the kidneys, they'll present with complaints of reduced or no urine output, flank abdominal pain, blood-stained urine. Hematological system, they'll present with complaints with suggestive of anemia like easy fatigability, headaches, dizziness, palpitations. For the liver, they'll be presenting with complaints of nausea, vomiting, right upper quadrant, abdominal pain, abdominal distension, jaundice, poor appetite, or early satiety. For the eyes, they'll present with complaints of blurred vision, scotomas, diplopia, that is double vision, transient visual loss, or fundoscopic findings of hypertensive retinopathy like flame hemorrhages, cotton wool spots, hard exudates, papilledema, or arteriolar narrowing. For pregnancy-related complications, this one now we are talking about severe preeclampsia or eclampsia. They present with complaints of severe headache, epigastric pain, right upper quadrant abdominal pain, visual disturbances, pulmonary edema, oliguria, elevated liver enzymes or thrombocytopenia, and critically they can be having seizures. That's why now we call it eclampsia, placental abruption, or fetal distress. These organ-specific manifestations require immediate escalation to intensive monitoring and targeted therapy. Once hypertensive emergency is suspected, time is very critical. An immediate high priority triage and rapid registration is done to minimize any delays. Then, obtain a focus history about the current medications, adherence to this oral antihypertensive, illicit substance use, pregnancy status, or recent trauma or symptoms onset, while simultaneously initiating assessment. Then transfer this patient urgently to an intensive care unit or high dependence unit. Proceed to perform a systematic survey adapted to the medical emergency. So let's begin with the primary survey. These are the A, B, C, D, and E's. Airway, assess for patency and protection. In patients with depressed consciousness, like for example those having a GCS of equal less than 8 out of 15, intubate early for airway protection and ventilatory support if indicated. For breathing, provide supplemental oxygen to maintain oxygen saturation of equal more than 94%, then initiate non-invasive or invasive ventilation as needed for pulmonary edema or respiratory failure. C is for circulation, establish large group intravenous access on two sides, and then draw urgent blood workups for complete blood count, renal panel, electrolytes, troponin, creatinine kinase, myoglobin band, ABGs, coagulation profile, urinalysis, and obtain 12-lead ECG. D is for disability, perform rapid neurological examination, including GCS, pupillary response, and focal deficits. Then plan for urgent non-contrast head CT scan if stroke is suspected. E is for exposure or environment, Fully expose the patient to identify any abnormal signs, then cover to prevent hypothermia. For secondary survey, conduct a thorough head-to-toe examination once the patient is stabilized. And then for the head and neck, check the pupillary size or reactivity, endoscopy for papilledema or hemorrhages, and then cervical spine tenderness. For the chest, auscultate for any crackles, wheezes, or diminished sounds, then also palpate for any tenderness. For the abdomen, assess for epigastric or right upper quadrant abdominal pain, then also assess the flanks for any tenderness and also the aortic pulsatility. For the pelvis and extremities, check for lower limbs edema, pulses, or any focal weakness. For the back, assess for any abnormalities that you can establish. And then there's the need to reassess the vital signs and neurological status frequently during this phase to identify any evolving complications. And then there's the need to review all initial imaging, laboratory results, and document and address any discrepancies or any new findings that can be established during this phase as well. In treating hypertensive emergency, the goal is to lower the mean arterial pressure by approximately 20-25% within the first hour, while avoiding excessive blood pressure drops that may precipitate tissue ischemia. This is followed by gradual reduction by approximately 160 over 100 millimeters of mercury over the subsequent 2 or 6 hours, then further normalization over 24 to 48 hours as clinically appropriate. Intravenous agents are preferred for precise titration. Selection depends on the dominant organ involvement, comorbidities, and institutional availability of these intravenous agents. Here are the most commonly used intravenous agents with practical dosing. We'll begin by looking at nicardipine. Initiate by infusion at 5 mg per hour, titrate by increasing 2.5 mg per hour every 5 to 15 minutes, with a maximum of 15 mg per hour allowed for nicardipine administration. The next agent is clevidipine. Start at 1 to 2 mg per hour, double every 90 seconds for the first few increments, then increase by 1 to 2 mg per hour every 5 to 10 minutes, with a maximum of 32 mg per hour. The next agent is labetalol, given as a slow bolus of 10 to 20 mg IV every 10 minutes up to a cumulative of 300 mg, or continuous infusion at 0.5 to 2 mg per minute. The next agent is esmolol, with a loading dose of 500 microgram per kg over 1 minute, followed by infusion of 550 to 300 microgram per kg per minute. Then we have sodium nitroprusside. Initiate at 0.3 to 0.5 microgram per kg per minute. Titrate upward slowly with a maximum of approximately 10 microgram per kg per minute. It requires arterial monitoring and thiocyanate level checks if used more than 24 to 48 hours. Close monitoring of vital signs is strongly recommended for accurate titration to minimize risk of rapid blood pressure dropping. Evaluate for secondary causes of hypertension such as renal artery stenosis, primary aldosteronism, pheochromocytoma, drugs of abuse such as cocaine, amphetamines, and phencyclidine. In the management of aortic dissection, the goal is to have a systolic blood pressure of less than 120 millimeters of mercury within 20 minutes and a heart rate of less than 60 beats per minute. Also consider measuring blood pressure in both arms. Initiate beta blockade first before you give a vasodilator. You can start by giving esmolol or labetalol. Esmolol is preferred and is given as a loading dose of 500 microgram per kg, then 50 to 300 microgram per kg per minute as a maintenance. This is done to achieve a heart rate of less than 60 beats per minute to reduce the shear stress. Then add a vasodilator such as IV nicardipine, clevidipine, and sodium nitroprusside. Those are the alternatives, only given after the beta blockade has been administered. Target systolic blood pressure of between 100 to 120 millimeters of mercury within the first hour if possible. Then plan for urgent vascular surgery or interventional consultation if needed. Do a CT angiography for confirmation as it's very essential. In the management of acute pulmonary edema or acute heart failure, the goal is to reduce the preload and afterload by use of vasodilators like nitroglycerin or sodium nitroprusside. This is then combined with loop diuretic like furosemide. Then we consider doing an invasive ventilation by use of a CPAP or BiPAP for respiratory support if the patient is hypoxic. Here you are going to target relief of congestion and gradual blood pressure lowering without hypotension. Also, while doing this, consider monitoring for cardiogenic shock. In the management of sympathetic crisis, this is when we have cocaine or amphetamine overdose, monoamine oxidase and tyramine interaction, pheochromocytoma. Benzodiazepines such as lorazepam or diazepam are used first. This is done to control agitation and sympathetic surge. Then alpha blockade with phentolamine or nicardipine or clevidipine is administered to control the sympathetic crisis. Avoid pure beta blockers alone as they risk an opposed alpha stimulation, which leads to worsening of the hypertension. Target stabilization of the hemodynamic and resolution of the symptoms. In acute ischemic stroke, permissive hypertension initially to maintain cerebral perfusion. Let's look at the blood pressure targets. If no thrombolysis, treat only if blood pressure is more than 220/120 millimeters of mercury, and if thrombolysis is planned, less than 185/110 millimeters of mercury. Use labetalol or nicardipine 5 to 15 mg per hour IV infusion or clevidipine 1 to 21 mg per hour IV infusion. Avoid aggressive lowering post-preperfusion, that is blood pressure of less than 140 millimeters of mercury in first 24 to 72 hours, as it may worsen the outcomes. In intracerebral hemorrhage, the goal is to have a blood pressure of between 140 to 160 millimeters of mercury that is sustained for at least 7 days to limit hematoma expansion and improve functional outcomes. Use nicardipine 5 to 15 mg per hour IV as the first line, or administer labetalol or clevidipine between 1 to 21 mg per hour IV infusion. If systolic blood pressure is more than 220 millimeters of mercury, continuous IV infusion with close monitoring is recommended. Stop antihypertensive if systolic blood pressure is less than 130 millimeters of mercury. Neurosurgical evaluation for evacuation if indicated, and then avoid large blood pressure variability. In hypertensive encephalopathy, gradual mean arterial pressure reduction of approximately 25% with nicardipine between 5 to 15 mg per hour IV infusion as the first line. Then administer labetalol or sodium nitroprusside. Avoid precipitous blood pressure drops to prevent watershed ischemia. Brain MRI to assess for posterior reversible encephalopathic syndrome. Target resolution of neurological symptoms, that is headache, confusion, seizures, and then also administer seizure prophylaxis if needed using levetiracetam. In acute coronary syndrome, the goal is to reduce the myocardial oxygen demand by use of nitroglycerin as the first-line agent for ischemia relief, plus a beta blocker if there is no heart failure. Then plan for urgent reperfusion by use of percutaneous coronary intervention as the preferred method. Target symptom control and hemodynamic stability, and avoid hypotension if there is right ventricular involvement. In acute renal failure, we have available agents as clevidipine, nicardipine, and fenoldopam. They are used to support renal perfusion. Avoid nephrotoxic agents, monitor urine output and creatinine closely. Then initiate renal replacement therapy, that is dialysis, for patients who have refractory oliguria, severe acidosis, hyperkalemia, or volume overload. In the management of severe preeclampsia and eclampsia, the goal is to have blood pressure of less than 160/110 millimeters of mercury, with definitive management being delivery within 24 hours, whether through induction or cesarean per obstetric indication. Administer magnesium sulfate for seizure prophylaxis, and for antihypertensive therapy, administer labetalol, hydralazine, or per oral nifedipine. Avoid blood pressures of less than 140/90 millimeters of mercury to preserve placental perfusion. Also monitor for HELP syndrome. This is where we have hemolysis, elevated liver enzymes, or low platelets. In all cases, continuous close monitoring is indicated together with serial laboratory checks, frequent neurological assessment, and multidisciplinary input. These are mandatory to detect progression or complications. Now, for take-home message, hypertensive emergency is an organ dysfunction due to elevated blood pressure. Lower the mean arterial pressure by no more than 25% in the first 2 hours to avoid hypoperfusion and organ ischemia. Then tailor your pharmacologic agent to the disease process and consider alternative sources for elevated blood pressure such as cocaine overdose or pheochromocytoma.